It is my pleasure and honor to introduce someone who needs no introduction, Dr. Henry Appleman, who is emeritus at the University of Michigan Ann Arbor, but yet still very active in his practice, and more than happy to hear his experience living the history of H. pylori. So, Henry.
Thanks, MC. It's a pleasure to be here at my age. I'm an old man, so you have to be careful of me. You might be old person yourself someday, hopefully. Okay, I was asked to talk about the history of H. pylori. And actually, H. pylori, there are three phases to H. pylori. One is before H. pylori was discovered, which I refer to as the Dark Ages. And then there was H. pylori, the time it was discovered. And then there was what's happened since H. pylori, which I refer to as the Renaissance. Are there any questions? So let me put this in historical perspective. Starting in the early 80s, there was this Australian pathologist, Robin Warren, who found curved bacilli on the surface of inflamed gastric mucosal biopsies. He wasn't sure what the implications were. He didn't know quite what that meant, but he saw them, and he let other people know. And this is what they looked like. You can see those little bacilli on the surface of the gastric epithelium and floating in the mucus coat, in the detached mucus coat. And about the same time, there was a clinician, Barry Marshall, who had a patient who had symptoms, and on biopsy of the stomach, there was the same curved bacteria and the same chronic gastritis. So he and Robin Warren teamed up. One had the anatomic capabilities, and the other had the clinical capabilities. So it basically was a marriage made in heaven. So they discovered that many patients with upper abdominal symptoms of varying types, including dyspepsia. One clinician told me dyspepsia was basically upper abdominal misery. Anyway, they had bugs in their gastric biopsy superimposed upon this active chronic gastritis. Now, what is this active chronic gastritis? Okay, I'm going to show you. This is normal stomach. And you can see that in the stroma or lamina propria, there are very, very few cells, hardly any inflammatory cells. In fact, in many stomachs, there are absolutely none. And then there are a lot of tubules. There are glands down at the base, and there are longer tubules, which are pits up on top. Well, this is chronic gastritis. Now here you can see that the stroma is full of inflammatory cells. And most of these cells in this particular type of chronic gastritis are actually plasma cells. So this is the chronicity aspect. In addition, there were often superimposed neutrophils in some of the epithelium, and this is the activity component. So now we have the active and the chronic. And these two Australian guys, found that the bacteria were present almost exclusively in patients who had this chronic gastritis, usually with activity. And they were also very common in patients with peptic ulcers, which involve both the stomach and the duodenum. And actually, most peptic ulcers are in the proximal duodenum. So these two guys thought that the bugs were probably etiologic related both to the chronic gastritis and to peptic ulcers. So they submitted their findings, preliminary findings, in a letter to the editor of a very prestigious British journal, The Lancet. And this was published in June 1983. And this is a picture from their letter to the editor. And the bugs are outlined with a word, two words actually. And these bugs are actually coated with silver in the Worth and Starry stain. And that's what Robin Warren used to bring out the bugs. And then about a year later, they submitted the findings in a more detailed publication, again to The Lancet. And this was published a year later in June 1984. And this is the publication, the paper that was published in The Lancet in 1984. Now, they named the bugs Campylobacter pylori because they thought they were very similar to a bug called Campylobacter jejuni, which was a cause of foodborne diarrhea. So you had diarrhea down below, and you had peptic ulcers up above. A great combination. Well, back about 15 years later, the organism was renamed to what we know now, Helicobacter pylori, after genetic sequences were performed and was found out that this was an entirely different type of organism. Now, it's interesting that these two very important publications were in The Lancet. It's a very prestigious British journal, but very few pathologists, surgical pathologists, read The Lancet. If I asked for a show of hands of who reads The Lancet now, I probably would get two. Well, somehow, by some miracle, we surgical pathologists found out about these bugs and their remarkable clinical associations. So there's a whole series of miracles that are involved in my presentation today. Another finding, a very important finding, was that this infection with this H. pylori was extraordinarily common, and it was estimated to occur in about 2/3 of the world's population, especially in developing countries, especially in areas of developed countries where there was poor hygiene and crowding. Soon after H. pylori was discovered, there were some diseases that were found to either be associated with the bugs or, more importantly, actually caused by H. pylori. So it was found that H. pylori caused almost all peptic ulcers. Peptic ulcer disease now became an infectious disease, believe it or not. In most cases were treated successfully with antibiotics, with anti-H. pylori medication, and other kinds of treatment like potent antacids and even surgical resection of the distal stomach was no longer needed. So this was a remarkable improvement in treatment. Now, how did these bugs on the surface of the stomach cause ulcers, especially in the duodenum? Very interesting question. Not totally satisfied, but it's felt that the bugs and the inflammation damaged the surface of the stomach and for some reason was able to increase the amount of acid production. So you had damaged surface and increased acid, and that was thought to lead to the peptic ulcers. This is a resected specimen from a large centrally ulcerating gastric adenocarcinoma. And back in the days of yore, I'm a little familiar with the days of yore. But I'll talk about my days in the yore period a little later. But gastric carcinomas were very common in the United States, especially in the early part of the 20th century. And this is what they looked like. This is kind of a typical tubule-forming gastric carcinoma with irregular tubules lined by awful-looking epithelium embedded in an inflamed fibrotic or desmoplastic stroma. In the United States, the number of gastric carcinomas has gradually been declining for decades. And here's just a printout of important gastric cancers from the American Cancer Society. And you can see that in the 1930s, gastric carcinoma was the most common cause of death for visceral cancers. And you can see how it gradually declined so that by the 2005 period, it was the least common of all of these cancers. And this is, the arrow now points to the time that H. pylori was discovered. And it was found out that the decline in gastric adenocarcinoma paralleled the decline in infection by Helicobacter pylori. And here's another printout showing from 1900 how H. pylori was gradually diminishing along with gastric adenocarcinoma. and presumably gastric adenocarcinoma was diminishing because there were fewer infected patients. It's very interesting in this chart to show that at the same time, Barrett's esophagus was becoming more common, more commonly found, and its complication, adenocarcinoma, was also becoming more commonly found. So this was a very interesting set of circumstances where we lost one cancer and got another. We never want to give up our cancers. They're very important to our sense of being and our well-being. However, in other parts of the world, gastric carcinoma, especially in Asia, was still very, very common, and it's still common to today. So H. pylori infection is the usual precursor of gastric adenocarcinoma worldwide, and this is the result of a sequential cascade which was defined by an old friend of mine, one of the giants in the study of gastric carcinoma, Pylori, Korea. And this is the cascade. It starts with infection by H. pylori, which leads to this chronic inflammation that I showed you already. And in some severe forms, there was destruction of some of the tubular structures in the stomach, which has resulted in atrophy, loss of stomach. And for some odd reason, intestinal metaplasia then became superimposed. And this led to non-invasive neoplasia, which we refer to as dysplasia, and eventually to invasive adenocarcinoma. Now, why did this happen? The answer is probably because of genetic types of H. pylori, which were carcinogenic. I won't go into that in detail. But anyway, it starts with the chronic H. pylori gastritis that I've shown you before. And this is atrophy. This actually is stomach. And there are very, very few tubules left. This is very, very severe atrophy. It's more than what we usually see. And then superimposed upon this, we can see intestinal metaplasia with the emergence of some goblet cells in some of these tubules. Finally, non-invasive neoplastic epithelium-forming tubules or dysplasia, and then invasive adenocarcinoma. Now, there's also a low-grade gastric B-cell lymphoma with an amazingly good prognosis that appears to develop as a result of hyperplastic lymphoid nodules as part of the inflammatory reaction induced by H. pylori. So here outlined in the red arrows is one of these gigantic hyperplastic lymphoid follicles. This is induced lymphoid tissue. The stomach has no normal lymphoid tissue. It has a few lymphocytic aggregates, but no well-developed lymphoid tissue. So this is induced by the H. pylori infection. And this can lead to low-grade B-cell lymphoma. And here's just a sheet of lymphocytes infiltrating and replacing much of the gastric mucosa. So about 75% of patients with this low-stage, low-grade lymphoma can be treated successfully by H. pylori eradication, indicating that this is an infectious disease that looks like a lymphoma. Weird things happen. The Lord, she works in strange and wondrous ways. So anyway, here's what H. pylori does. It induces this chronic gastritis, usually with activity, which in turn can lead to several things. One non-neoplastic peptic ulcers, and two neoplastic things. One adenocarcinoma through the atrophy intestinal metaplasia sequence, and the other is lymphoma resulting from hyperplastic lymphoid follicles. Now, for their discovery of H. pylori and everything that it led to, which is worldwide importance, Warren and Marshall were actually awarded the Nobel Prize in Medicine in 2005 for their discovery. Now, there's some other issues here we have to talk about. How about financial benefits? Well, if you really look at it truthfully, H. pylori has poured millions, maybe even billions of dollars into the medical system worldwide. This includes research, diagnosis, treatment, prevention of cancer, and ulcers, and a whole bunch of people have benefited from this. For instance, gastroenterologists have benefited because they now get to do way more biopsies and way more endoscopy, and they're responsible for most of the treatment. The interventional endoscopists are there because of localized resections. The surgeons are there because of the cancer. Hematologists are there because there's now a lymphoma. These lymphomas are gastrointestinal diseases that were stolen by hematologists. Finally, there are oncologists because they're cancers also that they can treat. And of course, we pathologists have benefited very dramatically. So H. pylori has actually supported thousands of people since its discovery. And it's led to a huge number of publications, various aspects of the bug. So it's a charity in its own right. It's fantastic. Here, I was involved as a co-author on 4 different publications of H. pylori, 3 of which were from 1989, which was just the time that the name was changed from Campylobacter to Helicobacter. And then the other thing is, who knows how many grants and promotions have resulted from H. pylori? It's just fantastic. Now, there's another benefit of H. pylori, and this is kind of a tongue-in-cheek benefit, because if H. pylori had not been discovered, there never would have been a paper on H. pylori negative gastritis. Think about it. So surgical pathologists also benefit from the discovery of the bug. We got many, many more biopsies, and we found new ways, often very expensive ways, of identifying the bug in biopsies. So routine use of stains for this bug became almost epidemic from time to time. The initial bug stain used by Robin Warren was a silver stain of sorry, which is kind of toxic. The techs don't care much to do it. Then we used a Diffquick, which we stole from the hematologists. They stole our lymphoma, we stole their stain. And then the immunostain, which finally replaced the others because it was more specific and sensitive. And some pathologists' practices even stain every gastric biopsy for H. pylori. Look at the extra income that they generate. This bug has given us great things. Well, back to my original subject, which was how did we pathologists function before we had H. pylori? So I started my pathology residency, believe it or not, 63 years ago, 21 years before the Lancet letter to the editor from Warren and Marshall. So I and all the other surgical pathologists were totally ignorant. We were totally oblivious to the existence of this organism. So there were still symptoms, these patients, there were still symptomatic patients and patients with ulcers, and many of them got biopsied. So we had a chronic gastritis. We were smart enough to at least go that far. It looked like it did after H. pylori was discovered, but we didn't know that. So this was a chronic gastritis. We still saw this chronic gastritis back in the days of yore, with the superficial plasmacytosis indicating chronicity, and the focal neutrophils in the epithelium indicating activity. And many of these patients many of the biopsies came from patients with duodenal peptic ulcers and other upper abdominal symptoms. But we diagnosed these biopsies simply as chronic gastritis. We had no reason to do anything else. And if they had neutrophils, then we threw in the word active, but we had absolutely no clue as to what the cause of this significant inflammation was. In fact, there was one very well-known pathologist who actually wrote a book on biopsy pathology in I think the 60s and 70s, who diagnosed this as, he got fancy and called them chronic superficial gastritis because much of the inflammation was in the upper part of the gastric mucosa. But he still didn't know. He wrote a book, but he didn't know what the cause of this superficial gastritis was. So many of the flame biopsies also had these gigantic hyperplastic lymphoid follicles, and sometimes these follicles were numerous and produced endoscopic or radiographic findings. And this led to the diagnosis of pseudolymphoma, a fake lymphoma. And here's just four papers that came out on pseudolymphoma. But once it was found out that these huge follicles were actually part of the inflammatory reaction due to H. pylori, the diagnosis of pseudolymphoma disappeared, and it's really never resurfaced. It's kind of silly. It got a lot of publications for a lot of people who were trying to go up in the academic world. So, and we also saw every so often characteristic cases of this low-grade gastric lymphoma, B-cell lymphoma, but we never knew they were caused by H. pylori. So anyway, back to my original question. We did the best we could considering the fact that we were totally ignorant. We knew absolutely nothing. We knew how to diagnose stuff, we just didn't know what it meant. So anyway, that's all I can say about H. pylori in the dark ages before there was H. pylori. So Helicobacter pylori actually was a miraculous gift to us and to the rest of the world. And to put this gift into an appropriate setting, this is from the ceiling of the Sistine Chapel, a painting by Michelangelo on the creation of Adam, which was a miracle. And here's another miracle from the same painting, the creation of Helicobacter pylori. So I can't do any more with this subject except give thanks to Marshall and Warren, without whose gift of H. pylori this talk never would have been possible. Thank you.
Any questions from the audience? I have a question too.
Again, not a question. Well, half a question. Henry, didn't Barry Marshall create a broth of Helicobacter and swallow it himself?
Yeah.
With biopsy before and after?
Yeah. The question was, did Barry Marshall infect himself, right? Yeah, he did. And he wound up with an acute gastritis. He never got the chronic. He never developed the chronic phase.
And the other comment I would add is Pepto-Bismol was effective in the dark ages because it contains a bismuth compound. I can't remember the name of bismuth from gallate, I think, that's very effective against H. pylori.
Yeah, Pepto-Bismol, the major component of Pepto-Bismol is bismuth. And bismuth is very effective antibacterial in this particular setting.
Henry, question for you. When I did my residency, and it's almost
I'm
30,
sorry?
I said I have a question for you.
Yeah.
When I did my residency almost 30 years ago now, I was working with a GI pathologist who was about to retire. And as we were looking at these biopsy, he wistfully told me that he wished he had had the open-mindedness because he had been seeing these bugs forever. He just didn't know what they were. Did you see something? Would you see these and ask yourself, I wonder what these are?
The question is, did I see these bugs before they were named? And the answer was, I wasn't a high-power guy. So I may have seen them, but I probably paid no attention.
Fair enough. Okay, thank you.